Uterine fibroids could be viewed as one of the most important public health problems. It can also be viewed as kind of like the holy grail of gynecology.
This is Breakthroughs, a podcast from Northwestern University Feinberg School of Medicine. I'm Erin Spain, Communications Director at Feinberg. It's the most common tumor found in women and is the cause of 200,000 hysterectomies in the United States every year. Yet, uterine fibroids have not been a frequent topic of medical research. Northwestern's Serdar Bulun leads one of the few research programs focused on the molecular and cellular abnormalities that may cause uterine fibroids and is investigating novel targets to treat the condition. Dr. Bulun directs Northwestern's Uterine Myoma Research Center and is the chair of the Department of Obstetrics and Gynecology. His work has greatly advanced uterine fibroid research and many other understudied conditions that affect women's health. Thank you so much for being here today.
Thank you. It's an honor to be here.
A majority of American women will develop fibroids at some point in their lives, and they may not even know about it, but some of these women, they need the medical intervention. Tell me a little bit about when do they require the medical intervention versus when is it something that you don't even know you have?
That's a great question. There is no straight answer to your question, partly because uterine fibroids are so common. If we would perform an ultrasound exam, we would probably find a fibroid in 80% of all reproductive age women. That's between the ages of, let's say, 18 to 50. And yet, a portion of these women will develop symptoms of fibroids. These include irregular uterine bleeding and anemia because of excessive uterine bleeding, recurrent pregnancy loss because fibroids may stick into the uterine cavity and may interfere with the embryo implantation. The same mechanism may give rise to infertility. Another bad part of fibroids are they can grow to very large volumes. For example, it's not uncommon to find a fibroid as big as a grapefruit, but sometimes most gynecologists, at least once or twice in their lives, would remember taking out a fibroid that's as big as like 3-4 pounds.
Wow, it's almost like a pregnancy is how it might feel or look on the woman.
Totally. I mean, these are all like possibilities. They may cause a whole variety of symptoms, and they may also mask like malignant disease such as ovarian cancer and may delay the diagnosis of these diseases. I should also mention that fibroids themselves have the potential either to be malignant when they were first discovered, or they may turn malignant over a course of years. Then we would call the tumor not a leiomyoma, but a leiomyosarcoma.
How often does that occur?
That occurs in about 1 in 300 to 1 in 1,000 cases, depending on what publication you read. It's rare, but it is there. And because of this, in fact, there is a concern that we might spread the disease if we do not take the leiomyoma as a whole, kind of like destroy it through a process called morcellation. Morcellation is done laparoscopically without opening the abdomen, and it involves an instrument that is called a morcellator. And morcellator kind of like destroys the fibroids, but it also spreads these cells across the abdomen.
And if they're malignant, then...
If they would be malignant, then that would be a real problem, although this risk could be as low as 1 in 300 to 1 in 1,000. And because of that, the use of morcellators have been either limited or sometimes if we have to use them, we use them in a plastic bag.
So it affects so many women, yet there hadn't been a big, robust research program about uterine fibroids until your program started. When was that, the early 2000s?
Right. It was, we became funded as a group in 2003 or 2004 by the NIH, and we were able to renew this program project twice. So the most recent renewal came just past August, and possibly we have brought to Northwestern more than $22 million overall to study uterine fibroids.
There really are a lot of different ways that uterine fibroids can affect women, and something that's pretty interesting is that African-American women are actually at greater risk than white women. As many as 80% will experience fibroids versus 70% of white women during their reproductive years. Do we know why African-American women seem to suffer more?
Uterine fibroids could be viewed as one of the most important public health problems. It can also be viewed as kind of like the holy grail of gynecology. It's the most common tumor of women. African-American women are disproportionately affected by fibroids, 3 to 4 times more common than in other races. And also, African-American women develop fibroids at an earlier age, about like 10 years earlier than Caucasian women. For example, African-American women may develop fibroids as early as in their 20s, whereas Caucasian women would typically develop fibroids in their 30s or later. The reason is not really known, and our group was one of the scientific group of physician scientists who threw some light on this. In fact, together with one of my trainees who came to visit us here in Northwestern from Japan, we conducted a study and we compared uterine fibroids from African-American women, Caucasian women, and Japanese women. And we found important molecular differences between all of these fibroids. For example, African-American women made more estrogen in their fibroids. Therefore, they contain more estrogen in their fibroids. Estrogen is important because it enables progesterone to do the final tumorigenic action on fibroids. It prepares uterine fibroids to be for response to progesterone. And progesterone is the tumorigenic hormone. Therefore, both estrogen and progesterone are important, but estrogen plays more of a permissive role, whereas progesterone is the final tumorigenic hormone. Yet, progesterone will need estrogen for it to be able to act.
And the fact that African-American women, it does seem that they are able to produce more estrogen. That's something that's pretty important for the doctors treating these women and the scientists who are looking for cures for fibroids.
You're absolutely right. In another group, we found that progesterone receptors were expressed at a higher level. And in this racial group, we concluded that these types of tumors would be more responsive to progesterone. If we know all these details, these molecular details, then we would be able to design specific, patient-specific, high-precision treatments for different groups of patients. And I think this gets into the area of precision medicine.
Which is very exciting. You might be able to come up with a therapy just for that person and their level of estrogen.
Totally. I think that's how we should be thinking about. We should think whether a certain patient, based on her either like racial origin or more importantly, genomic or genetic makeup or the genetic makeup of the fibroid. The question is this patient going to respond to a specific type of treatment? For example, aromatase inhibitors are a group of medications that stop estrogen production. and that works in fibroids, but in a group of fibroids. Progesterone antagonists, the medications that stops or antagonizes the action of progesterone, also could be therapeutic, but not everybody responds again. So it would be really important to do genetic tests to find out whether this group of patients or this individual patient will respond to a certain type of treatment.
So genetics and epigenetics play a role in the research that you're doing in uterine fibroids.
One of the major breakthroughs for uterine fibroids happened in Finland. Actually, a group of Finnish investigators, they took fibroid tumors and they looked at their genetic makeup, and they found this specific mutation called MED12 in 70% of all fibroids. There's a second mutation called HMGA2 that also accounts for another 15% of all fibroids. So 85% of fibroids happen because of two somatic mutations. Somatic mutation means it's not the kind of mutation that could be passed on to a next generation, but it does occur in a tissue in an adult individual, and it just contributes to a certain disease like this fibroid. Our contribution has been that we demonstrated this phenomenon. After these mutations were published in 2011, in 2012, 13, and until now, what we demonstrated was each fibroid starts from a single stem cell. So what happens is during each menstrual cycle, a woman's uterus thinks that it's going to get pregnant, and it gets ready for pregnancy. And this also involves the normal uterine muscle called myometrium to expand by activating its stem cells. So if one of these normal stem cells that would be intended to accommodate a normal pregnancy would be affected by this mutation called MED12, for example, then it does become responsive more abnormally to progesterone and keeps growing from a single stem cell. A whole fibroid tumor is formed. So we demonstrated this phenomenon. And in fact, I published the initial summary of our findings in a 2013 New England Journal of Medicine article, which is a review article, but it's kind of like summed up all of our contributions until then. And since then, we furthered our work by looking at the effects of these mutations on the epigenetic makeup of the cell. So a mutation changes the code of DNA. Therefore, the protein that is encoded by the DNA becomes defective if it is, and then it doesn't really work. So this is like how mutations work. Epigenetics does not involve change in the code of DNA. Epigenetics is a science as to how DNA is read and programmed so that it would make these proteins. So some portions of the DNA is closed, it doesn't make proteins, and other portions of the DNA is open and it makes proteins. That's what separates different tissues. That's why our eye is different than our liver, although they both contain the same DNA. So we looked at this phenomenon in fibroids and see how these mutations changed how the DNA is programmed. And what we found is the stem cells change their epigenetic programming to become mature cells. And then they become like terminally differentiated, and then they die off. If new stem cells do not replace these differentiated stem cells, then the tumor would disappear, would die off. Unfortunately, the stem cells are very smart, and through asymmetric division, they also replace themselves. Part of them replace stem cells, the other part becomes differentiated to these larger cells, which make the bulk of the fibroid. So we figured that if we can find ways to deplete the stem cells, then we can kill these tumors. And this is what we are working on now. And we are targeting the epigenetic programming machinery of the cell to increase its rate so that the stem cells would very fast differentiate into these like terminal cells and die. And that's kind of like what we are working on right now.
So that's an epigenetic therapy that you're working on.
Absolutely, yes.
And these series of papers that you talked about, starting from 2011 all the way to the review in 2013, that really laid a lot of groundwork, not only for your team, for other people all over the world. And how close are we to something like this epigenetic therapy that you just spoke of and described?
I think we are fairly close. However, we are limited by the availability of medications and their side effects. Usually, most of the medications that we use to treat fibroids, they work in animal models. We have these PDX models in which we place human cells or human tissues in mice and then treat these mice with medications. If these medications work, because these are primary human cells, there's a very good predictive value that they would also work in humans because they work on like in vivo systems on human cell types. The problem is the side effects. Like although these drugs may kill the tumors, they may also have some unwanted side effects on other tissues such as the liver and a whole variety of tissues. So the major limitation is, again, side effects. We are hoping that drug companies or other researchers would follow our initial findings and work on developing these medications and make them ready for use in patients.
Now that you've received this renewal from the NIH funding, and again, this is almost a decade of study with this grant, talk a little bit about some of the ongoing projects and any new work that's going to be supported by this grant renewal.
So we have like 3 projects that are ongoing. We have 2 projects at Northwestern. One is run by Dr. Pingyin and myself. And we do look at the effects of these MED12 mutations on the epigenetic makeup of the cell and how these mutations alter the cells with respect to their response to progesterone. Because progesterone may act on normal tissues for normal processes, suddenly it becomes a tumorigenic hormone in these fibroids. We are asking the question why this is, and we have a lot of leads. We are also looking at, as we discussed earlier, how these mutations change the epigenetic makeup and whether we could make use of this to develop new treatments. Dr. Debu Chakravarti and his group are looking at HMG-A2 mutations. Debu works with Dr. J.J. Wei from pathology, and together they are trying to understand how HMG-A2 mutations are changing the cell, the epigenetic makeup of the cell, and their responsiveness to hormones in different ways. And finally, our third partner is at UCSF. His name is Alex Rajkovic. And Alex was able to recapitulate the human mutation, which is a very complex mutation, by the way. It's a heterozygous mutation. It involves only one of the alleles, whereas the second allele remains normal. And this MED12 gene is located in the X chromosome, so that's also very interesting. And Alex, through very sophisticated work, was able to recapitulate this human mutation in mice. And these mice, they did develop fibroid tumors. So we concluded that his mutation must be relevant. And we are working very closely with him on these mice to test some of the medications and try to understand what types of cells are involved in these tumors. For example, we are doing single-cell sequencing both on human tissues and mouse tissues. We are very, very excited about our new directions.
It's very exciting, and it's a robust research program, all those different projects you just described. But it's also important to know you are treating patients. You're a physician at Prentice Women's Hospital. You are seeing women coming in not only with uterine fibroids, with many different gynecological diseases. Tell me a little bit about that work that you do in the hospital. How often are you in clinic?
I'm in the clinic 1 day a week on Mondays. By training, I'm an obstetrician and gynecologist, followed by subspecialty training in reproductive endocrinology and infertility. So I do see a lot of patients who have difficulty achieving pregnancy. And also I do see a number of patients with uterine fibroids and also with endometriosis. Endometriosis is a condition which causes chronic pelvic pain and infertility. In fact, I would say endometriosis is the most common cause of chronic pelvic pain in women. If you put together uterine fibroids and endometriosis, they account for more than 75% of all hysterectomies that we perform in women.
That's an incredible number.
Right. These are the two most important benign gynecologic diseases that affect reproductive age women.
So was it meeting with these patients and treating these patients or looking for treatments for these patients a reason why you decided to get into the research part of your career? Were they inspiring you at all?
If I hadn't seen patients in the clinic, I'm not sure if I would be as driven and inspired to continue this line of research. We've been conducting this type of research on endometriosis, uterine fibroids, and breast cancer since 1993 in my lab, and we have probably brought in more than $75 million of NIH funding to the institutions that I worked in. Most of this money came to Northwestern. That's a huge drive, as you could see. The major source of inspiration would be my patients who are, constantly helping us, inspiring us to continue to work on this. They also are always willing to help out by participating in research, by providing tissue samples, by participating in clinical trials. And so that's a very important part of our inspiration.
Because I'm sure a lot of the stories that you come across with the patients, it is heartbreaking if they're dealing with infertility or other issues during this reproductive time in their lives, and something like uterine fibroids is preventing them from sort of having a family. That's pretty powerful.
Totally correct. I mean, although we define uterine fibroids as a benign disease, it's not that benign. I mean, it destroys a lot of lives. If the tumors are very big, we may not be able to remove them surgically to allow the remaining repaired uterus to go through surgery, and they recur all the time. And honestly, I mean, there are no meaningful medications to treat fibroids right now. The only medication that was approved for the treatment of fibroids was called leuprolide acetate, that class of medications, and these GnRH agonists were approved in early 1990s. And since
it's been
then,
a while. Yeah.
nothing happened
Yeah.
in the field. So there's a huge need for more research, more attention, generation of more treatments.
Well, we are very excited about the research you're doing. It sounds like you're laying a lot of tracks here for the next generation and to come forward and maybe find some new treatments.
Well, thank you. Thanks so much for providing this opportunity.
If you enjoyed this episode of Breakthroughs, please rate us on Apple Podcasts. If you are in the medical field, you can claim CME credit just for listening. Go to our website, feinberg.northwestern.edu, and search Breakthroughs CME.